Welcome everybody to Daria today. We're lucky enough to have one of our GP registrars who's currently at St Vincent's Hospital doing addiction placement with us, Georgie Mair, and she's going to be presenting on clinical management of cannabis withdrawal. So take it away, Georgie, please.
Thank you, Chris. Hi everybody, I'm Georgie, I'm one of the registrars. So I'm going to be presenting a literature review today on the clinical management of cannabis withdrawal. I'd like to begin today by acknowledging the Gadigal people, the traditional custodians of the land on which we meet today, and to pay my respects to their elders past, present and emerging. I extend that respect to any Aboriginal or Torres Strait Island people here today. Next slide, please, Lucy. So just to outline the presentation today, so I'm going to begin by discussing sort of the aims of the review, then a bit of a background about cannabis withdrawal. The methods they used in this review, obviously, is they just had a look at all the current literature, so and then the results, a quick case study, and new developments in the field and conclusions. Okay. So this review describes the diagnosis, prevalence, course of management of cannabis withdrawal and highlights opportunities for future clinical research. Next slide, please. So just a bit about the background of cannabis withdrawal. So obviously cannabis withdrawal refers to symptoms that occur after abrupt cessation or significant reduction in the use of cannabis products containing THC. The main psychoactive component in cannabis. These symptoms occur most often in regular and heavy cannabis users, and the most common symptoms are sort of anxiety, irritability, anger or aggression, disturbed sleep, depressed mood, and sort of loss of appetite. Less commonly reported physical symptoms can be like chills and headaches, a bit of tension, sweating, tummy pains occasionally. Cessation of short-term CBD, a non-psychoactive cannabinoid, does not appear to result in withdrawal. And with THC, symptom onset typically occurs kind of 24 to 48 hours after cessation, and most symptoms generally peak at days sort of 2 to 6. The duration and severity of cannabis withdrawal is associated with the amount of cannabis consumed before cessation, but it can also vary considerably. In heavy users, withdrawal symptoms can occur for up to 2 to 3 weeks or longer, even up to, 2 to 3 months. Next slide, please, Lucy. So a bit about the prevalence. A meta-analysis pooling studies of more than 20,000 regular and dependent cannabis users estimated that 47% of individuals reported cannabis withdrawal measured by standardized scales. They found that the prevalence in community samples was 17%, increasing to 54% in outpatient samples, such as drug and alcohol clinics, the people in those clinics, and then 87% reported withdrawal symptoms who were inpatients for inpatient management. The finding that the prevalence of cannabis withdrawal syndrome was substantially higher in clinical populations, particularly inpatient samples, indicates that these people are more likely to present to clinicians for help compared with those without cannabis withdrawal syndrome. And like I said, the prevalence of withdrawal symptoms is is going to be higher in users with a history of daily cannabis use, and people with concurrent cannabis and tobacco use and other substance use disorders. Next slide, please, Lucy. So cannabis use disorder is characterized by persistent cannabis use despite negative effects on the social functioning and physical or mental health of the user or the health of other individuals. 2 diagnostic systems classify and define the severity of the disorder, the DSM-5 and the ICD-11, which I'm sure everyone is familiar with. I've just included the DSM-5 here in the slide. The severity is coded as mild, so that's sort of the presence of 2 or 3 symptoms, moderate, the presence of 4 to 5, and then severe, the presence of sort of 6 or more symptoms. Next slide, please, Lucy. So a bit about the neurobiology of cannabis and the receptors that it acts on. So the cannabis plant contains approximately 120 cannabinoids, the most studied of which are THC and CBD. The body's own endogenous cannabinoids act as partial agonists of the body's CB1 and CB2 receptors, as does THC. Whereas CBD acts as an allosteric modulator of these receptors, which basically means that it binds to the receptors and consequently changes the receptor's response to a stimulus. The psychoactive effects of THC are underpinned by its strong affinity to the CB1 receptors, which are predominantly distributed in the brain. THC has a much lower affinity for the CB2 receptor that is predominantly found in the immune cells in the peripheral nervous system. And conversely, CBD has a stronger affinity for the CB2 receptor, but it has a relatively, much lower affinity for either receptor compared with THC. Activation of cannabinoid receptor 1 and 2 by cannabinoid ligands inhibits production of adenylate cyclase. And also this activation promotes exocytosis of a variety of neurotransmitters, which act broadly on the central and peripheral nervous system. There is good neurobiological evidence and clinical evidence for a pharmacologically specific cannabis withdrawal syndrome. CB1 antagonists precipitate specific withdrawal symptoms in animal models of cannabis dependence. And in human studies, administration of CB1 agonists, THC, blocks or relieves withdrawal symptoms. Neurobiological and clinical studies indicate that symptoms of cannabis withdrawal are consistent with the core symptoms of other substance withdrawal syndromes and reflect neurochemical changes in the limbic system. Next slide, please, Lucy. So withdrawal severity. So in most instances, cannabis withdrawal is not severe and does not have a high risk of severe adverse outcomes. There can be medical or psychiatric comorbidities that increase the risk of that severity and therefore the requirement of additional management. The most clinically relevant criteria is the degree of patient distress, or impairment in functioning. This can be assessed both subjectively, so things like anxiety, sleep quality, and objectively, so things like fever, shakes, that kind of stuff. The 2 most widely used cannabis withdrawal scales are the 16-item marijuana withdrawal checklist, MWC, and the 19-item cannabis withdrawal scale, CWS. Both these scales were developed before the DSM-5, and there is considerable overlap of features between the DSM-5 and both the other scales, but not complete concordance. By comparison with other substance withdrawal scales, such as alcohol, there's been limited psychometric validation of various cannabis withdrawal scales. Next slide, please, Lucy. So different things to consider: differential diagnosis of cannabis withdrawal syndrome. So, a lot of clients that use cannabis are polysubstance users. So, a study found that 3 in 4 cannabis users seeking treatment will have another substance use disorder. And in a US survey, people with cannabis use disorder diagnosed in the past 12 months were 6 times more likely to have an alcohol use disorder and 9 times more likely to have another drug use disorder. A key tool, I guess, in differential diagnosis is the cessation of cannabis use with 24 to 48 hours of onset of symptoms, and an improvement in symptoms after 4 to 7 days of abstinence with, obviously careful assessment of other substance use and abstinence patterns. a thing to bear in mind as well is that polysubstance use may increase the severity of a patient's withdrawal, cannabinoid receptors are major targets, directly or indirectly, for many other drugs of abuse, including prescription drugs. And then I guess, additive withdrawal effects may occur when cannabis is combined with other central nervous system depressants such as alcohol, opioids, and some benzos. And sort of as previously stated, people who are using tobacco and spinning tobacco with cannabis are more likely to report withdrawal symptoms than people who don't use tobacco with the cannabis. And I guess, when assessing patients, you need to take into consideration the withdrawal for the highest risk substances. So I guess, your alcohol and your benzos, things like that. Other things to consider are psychiatric comorbidities. So there's a well-documented dose-response relationship between the level of cannabis use disorder and psychiatric comorbidity. You need to assess concurrent mental health disorders, symptoms of which might be exacerbated or even mimic cannabis withdrawal. In a study in Australia, they found that 70% of adults who met cannabis use disorder criteria in the past year had at least one other psychiatric disorder. And as we all know, heavy cannabis use can increase the psychosis risk, especially in people who already have a diagnosis of schizophrenia. The other thing to consider is, other physical comorbidities, and I guess a comprehensive medical review with an emphasis on GI and neurosystems is always recommended. Next slide, please, Lucy. So inpatient admission is rarely required for uncomplicated medically assisted withdrawal. Supervised or inpatient treatment for withdrawal should be considered if the patient is a polysubstance user, has a history of previous complicated withdrawal from cannabis or even other substances, or if the withdrawal is going to exacerbate a current mental health condition, which would then be likely to produce a major functional impairment for that patient, or maybe increase the risk of self-harm. So if that is the case, then I would consider supervised inpatient withdrawal. And I guess also, even if a patient isn't using any other substances with the cannabis, but if they have had a history of complicated ambulatory withdrawal, then again, they should be considered for inpatient support. Next slide, please. So just a bit more about S withdrawal and the time frames. I quite like this graph that the study used. So it displays kind of typical reductions. As you can see, the green line sort of downtrending and then leveling out. So this is the typical reduction in the mean daily creatinine normalized urinary sort of THC. So like a urinary metabolite of THC, and its levels after abstinence in heavy chronic cannabis users. The early phase of withdrawal, as you can see, is usually characterized by insomnia, irritability, decreased appetite, shakiness, and these early symptoms are kind of most likely to peak at days 2 to 6 and improve as the THC levels reduce over the 7-day abstinence. Anger, aggression, and depressed mood may occur as early as 1 week into the withdrawal, but typically peak after 2 weeks of abstinence. And sleep disturbance may continue for several weeks, if not longer. There's a large amount of variation in the course and severity of cannabis withdrawal. Some patients who report low levels of cannabis use and few cannabis use dependent symptoms, e.g. let's say only 2 out of that DSM-5 criteria, do report uncomfortable withdrawal symptoms that significantly impair their day-to-day functioning. And some studies of recreational and regular cannabis users and those seeking treatment report that females actually may experience more severe cannabis withdrawal symptoms than males, even when sort of matched for cannabis use and other demographic characteristics, as they have prolonged urinary elimination. I quite like this graph, and I think you know, sometimes it can be, you know, better to give patients a more visual representation of, I guess, what to expect from their cannabis withdrawal, and sort of, you know, managing their expectations, you know, via patient education. Next slide, please, Lucy. So a bit about non-pharmacological interventions first. So, you know, to our knowledge, there are no high-quality studies on the most effective behavioural approaches, and no studies that compare, you know, the effectiveness of behavioural and pharmacological approaches to managing withdrawal. Most pharmacological studies of withdrawal include some form of concurrent behavioural intervention, but the differential efficacy of these behavioural approaches has not been well assessed. Despite the limited evidence, standard clinical practice includes psychoeducation on the cause and symptoms of withdrawal, you know, coping with cravings, exercises, nutrition, physical exercise, sleep hygiene, and can also include things like motivational interviewing and CBT. Next slide, please. So now I'm going to talk a bit about the studies that this review looked into for pharmacotherapy for cannabis withdrawal. So, you know, cannabis is obviously the most widely used illicit substance worldwide, yet there are no current medications approved to manage cannabis withdrawal syndrome. Research on medically assisted withdrawal has increased during the past 15 years, but remains more developed for other drugs like opioids, alcohol, benzos, those kind of things. So this review looked at 19 placebo-controlled studies. 16 were randomized designs, and only 9 of these studies reported cannabis withdrawal as a primary outcome. And of these 3 randomized designs, only 3 reported more than 50 participants in the medication arm. So out of these 3 studies that had over 50 participants in the medication arms, 2 found a significant benefit from medication over placebo, which I'll discuss now. So the first one is a medication called dronabinol. Dronabinol is an orally active form of THC, and like THC is a partial agonist at the cannabinoid receptors, especially type 1. It is synthetically manufactured and registered in the US by the FDA for the treatment of anorexia in patients with AIDS and for the management of chemotherapy-induced nausea and vomiting, where sort of standard antiemetics have failed. So this study, it was a randomized, double-blind, 12-week outpatient study of cannabis-dependent users. The primary outcome was cannabis abstinence, and the secondary outcome was cannabis withdrawal. So 79 patients were titrated to 20 milligram twice daily over a period of 1 week, or placebo, of which there were 77 in this arm. So both groups also received weekly coping skills interventions and motivational enhancement therapy. And the study found that dronabinol increased treatment retention and reduced cannabis withdrawal symptoms measured by the composite withdrawal scale over time compared to the placebo. And the medication was really well tolerated and no difference in side effects between the 2 groups. Obviously, the limitations of this study is that the cannabis withdrawal was not the primary outcome, and there was also greater than 1/3 attrition among studies. So the second one I'm going to talk about here is quetiapine. So as we know, This is a antipsychotic medication. So this trial was a randomized, double-blind, placebo-controlled study of cannabis-dependent individuals seeking treatment. So the primary outcome were measures of daily cannabis use, and secondary outcomes were weekly urinary THC concentration, cravings, withdrawal, sleep problems, and study retention. So 67 participants were randomly assigned to titrate to dose target of 300 milligram or maximum tolerated quetiapine, or placebo, of which there were 64 participants. The study found that quetiapine treatment significantly reduced cannabis withdrawal, with each week in the study withdrawal scores decreased on average by 10.4% in the treatment and by 6.5% in the placebo arm. But there was no difference reported in things like cravings or sleep problems between the two groups. The limitations of this study is that there was a huge dropout, 44%, prior to completion. And again, a replication RCT is required with, cannabis withdrawal as the primary outcome. Next slide, please, Lucy. So, in the studies that used standardized measures of cannabis withdrawal syndrome, 6 reported a greater improvement in those given a cannabinoid medication compared with placebo, of which we'd already mentioned 2. So the next medication I'm going to discuss is nabiximols, of which there were 2 studies. So nabiximols is the only medicinal cannabis included on the Australian Register of Therapeutic Goods. It's a combination of cannabidiol and THC in a spray, and it's indicated for muscle relaxation for spasticity in MS. So the 2 studies presented both actually had cannabis withdrawal syndrome as their primary outcome. So the first one on the left, this was a randomized double-blind inpatient study of cannabis-dependent users who were using on average 23 grams per week. 27 patients completed a 6-day regime of nabiximols, providing a maximal daily dose of 86.4 milligrams of THC and 80 milligrams of CBD. And there were 24 participants in the placebo arm. So both groups also received CBT during the 9-day admission. And the study found that nabiximols reduced cannabis withdrawal scale scores for the duration of treatment and improved retention rate relative to the placebo, and there were no serious or adverse events or differences in side effects between the groups. Limitations of this study, I guess, that we need a larger scale validation RCT to assess their effectiveness, including sort of a dose response data. And the study also found that when the treatment was taken away, as in the nabiximols was stopped, there was clients did report withdrawal. I think about 1 in 3 people reported that there was some withdrawal. So the second study with the nabiximols, so this was a 16 cannabis-dependent participants completed an 8-week double-blinded trial consisting of 4 weeks where they smoked as normal, and then 4 weeks where they were abstinent. So they'd smoke for a week and then have a week of abstinence, smoke for a week, have a week of abstinence, and so on. And during the 4 cannabis abstinence weeks, they administered self-titrated and high-dose nabiximols, nasal spray, and self-titrated and frequent dose placebo spray. And the primary outcomes of the study were medication tolerability, serious adverse events, cravings, and withdrawal. And they found that high fixed dose of nabiximols were well tolerated and significantly reduced withdrawal using CWS and MWC scales during those abstinence periods compared to placebo. Cravings were not reduced. And again, sort of the study limitations of it, small sample size, and it was short duration. Next slide, please, Lucy. So This study used oral THC, so I think they, similar to dronabinol. So it assessed whether oral administration of THC effectively suppressed cannabis withdrawal in an outpatient environment. And the primary outcome of this study was withdrawal. And to obtain information relevant to determine the potential use of THC to assist in the treatment of cannabis dependence. So the method of this study, so they had 8 adult daily cannabis users who were not seeking treatment to participate in a 40-day trial, again with similar to the previous study I discussed. So it was sort of week on smoking, week off. And in the abstinence weeks, they would administer either placebo or 10 milligram TDS of oral THC or 30 milligram TDS of oral THC. And these were sort of 5-day periods separated by a week of then smoking cannabis. Next slide, please, Lucy. So these were the results of the study. So the open circles that you can see in each graph, so they represent the 3 smoking as usual conditions, and the closed circles represent means during the 3 abstinence conditions. So the comparison of withdrawal symptoms across conditions indicated that 1, the lower dose of THC, so the 10 milligram TDS, reduced withdrawal discomfort, and 2, the higher dose, so 30 milligram TDS, produced additional suppression in withdrawal symptoms, such that symptom ratings didn't actually differ from the smoking as usual conditions compared with that high dose. The efficacy of these doses for suppressing cannabis withdrawal suggests that oral THC might be used as an intervention to aid cannabis cessation attempts. Obviously, again, there's huge limitations with this study in the fact that it was an outpatient study. So, you're unable to obtain whether participants might have been smoking, without the study designers knowing. And obviously, it's a small sample size again. Next slide, please, Lucy. So this study looked at gabapentin. It was a randomized double-blind study of treatment-seeking cannabis-dependent outpatients. 25 patients received gabapentin up to 1,200 milligrams a day for 11 weeks, followed by tapering, and there were 25 patients in the placebo arm. Again, in this study, individual counselling was also provided to both groups. The results found that gabapentin significantly reduced cannabis withdrawal and cannabis use over the course of the study compared with placebo. And also they found that mood and sleep were also reduced. Medication was again well tolerated and no difference in side effects between gabapentin and the placebo. Limitations of this study is that only 1/3 of the patients completed the trial. So that was a bit of a shame. Next slide, please, Lucy. So 10 studies that were reported in this review did not report a greater improvement in those given a cannabinoid medication compared with placebo. So I'm just going to briefly touch on them as well. Next slide, please, Lucy. First one would be bupropion. So this is a medication used for smoking cessation. So in this study, cannabis withdrawal was the primary outcome. It was a randomized double-blind study of participants with cannabis use disorder, and they were asked to cease cannabis for 14 days. 10 participants received bupropion, sustained release, so 150 milligrams once a day from days 1 to 3, and then 150 milligrams twice a day from days 4 to 21. And only 5 in this treatment arm completed the study, and 12 in the placebo arm, and only 4 completed the study. So really small numbers in this study. Again, all patients received motivational enhancement therapy, but there was no statistically significant difference between bupropion sustained release and placebo on withdrawal scores. So the second one is a FAAH inhibitor, PF04457845. So This inhibitor basically potentiates endocannabinoid signaling by inhibiting FAAH, the enzyme that degrades the endocannabinoid anandamide. This study, so it was a randomized double-blind for inpatients for 5 to 8 days, followed by 3-week post-discharge monitoring. So cannabis withdrawal was the primary outcome. And this patient was only with male participants. So 46 were administered 4 milligram once daily over the duration of the study, and 24 patients received placebo. So they found that the inhibitor significantly reduced cannabis withdrawal in the early stages, so days 0 to 2, but not in the later stages, stages 2 to 4. And it also did result in less cannabis use post-discharge compared to placebo. However, sort of as on the whole, it didn't significantly reduce withdrawal for that majority of the withdrawal period, just the first couple of days. Lithium, which is used as a mood stabilizer. So this study, again, randomized double-blind study. So 19 patients received 500 milligram of oral lithium and 22 patients received placebo for 8 days, and found that there was no, lithium didn't significantly affect the cannabis withdrawal scores compared to placebo. A study using dronabinol, which we sort of previously discussed and did find good effects with, it's that orally active form of THC, that as well as lofexidine, which is similar to clonidine, so it's an alpha-2 adrenergic agonist medication used to treat hypertension and opioid withdrawal. So this study was a randomized controlled trial, and it was done by the same authors as the previous study that I discussed on dronabinol. And they found that there was no benefit from adding lofexidine to dronabinol on cannabis withdrawal compared with just placebo in cannabis-dependent individuals. Next slide, please, Lucy. So another study on nabiximols. So in this study, there were 20 cannabis use dependent outpatients, and they were randomized to as needed, so sort of self-titrated nabiximol spray up to 113.4 milligrams of THC and 105 milligrams of CBD, and 20 participants were randomized to placebo daily for 12 weeks. The primary outcomes of this study were tolerability and cannabis abstinence, and the secondary outcomes were withdrawal. And both groups received some motivational enhancement therapy and CBT, and this study found that there was no difference between nabiximols and placebo in the withdrawal scores. However, over the 12-week study, there was a reduction in cannabis cravings that statistically favored the nabiximols. So that was good. So extended release zolpidem, so this is used in the short term for insomnia. So in this study, heavy cannabis users alternated between cannabis use and cannabis abstinence for 3 days, and extended release zolpidem or placebo was administered at bedtime during the abstinence periods. The primary outcome of this study was sleep quality, and cannabis withdrawal was secondary. And there was no difference between the zolpidem or placebo and cannabis withdrawal scores. Guanfacine, so this is a medication used for ADHD. This was an open-label, single-arm pilot trial of 22 cannabis-dependent treatment-seeking outpatients. And participants were titrated to a maximum tolerable or target dose over a period of 2 weeks. This was then lengthened actually to 8 weeks due to sort of greater than expected side effects and adverse events. And the study found that there was no significant change in withdrawal symptom severity compared to placebo. Escitalopram, so used to treat depression and generalized anxiety disorder. in this sort of randomized double-blind study of treatment-seeking cannabis-dependent outpatients. They received either 10 milligram per day of escitalopram and 26 received placebo for 9 weeks, plus then a 14-week follow-up. So cannabis withdrawal was a secondary outcome, and as were depression, anxiety scores were also secondary outcomes. Again, this study found that there was basically no different to placebo on withdrawal scores for anxiety or depression, and also for withdrawal. So nabilone, so this is a synthetic cannabinoid which mimics THC. So this study, cannabis-dependent outpatients were randomized to either 2 milligram a day of nabilone or placebo for 10 weeks. And again, the study found no difference between the two on cannabis cravings or anxiety. Next slide, please. So the research on medications for medically assisted withdrawal in the treatment setting, in treatment-seeking cannabis-using populations, is limited by the small number and low quality of studies. Larger replication studies are required to test the efficacy of agents that have shown promising results in the small studies. And medically assisted withdrawal largely treats its symptoms with agents known to reduce them, but many of these drugs have not been well studied in people with cannabis use disorder, and their off-label use is of uncertain efficacy and safety. Next slide. So in clinical practice, short-term symptomatic medications have been used for non-specific general cannabis withdrawal syndrome features, and for specific withdrawal features, e.g. sort of sleep and nausea, that kind of thing, to improve, patient comfort and retention in the withdrawal program. As you all probably well know, for things like anxiety and agitation, we can use things like diazepam, for nausea, antiemetics like metoclopramide, ondansetron. Olanzapine and quetiapine can be used for any psychotic symptoms, and we do occasionally use olanzapine in Gorman for agitation. And then, for sleep disturbance, we can use diazepam, promethazine, things like that. As with all prescribing, though, a comprehensive medical drug and alcohol history should guide the use and the doses of these medications. And, all medications do have side effects, and these need to be balanced against the potential benefits. Next slide, please. So I'm now going to talk about a common complex presentation that this review discussed. Polysubstance use is common in cannabis users, and as a psychiatric comorbidity. So a 48-year-old male presented to his GP with stomach cramps, headache, chills, loss of appetite, and elevated anxiety symptoms that have prevented him from working for 48 hours. He stated that while he's been off work, he's heard infrequent but multiple unfamiliar voices telling him that he's going to lose his job. The patient reports that he has been having relationship problems with his partner of 15 years, primarily due to his substance use. He ceased all substances 60 hours prior to the assessment. Next slide, please. So, sorry, next slide, Lucy. Thank you. So past medical history of hypertension, disturbed sleep, mild to moderate sleep apnea, of which he's on CPAP, obesity with a BMI of 35. He's got elevated anxiety, depression. He denies any history of schizophrenia or psychotic disorders and denies any thoughts of self-harm at this time. So his current medications, he's on escitalopram, 20 milligram, captopril, 25 milligram, and like I said, CPAP, but he's not compliant with any of these medications. Next slide, please. So substance use history. So he reports that he's currently smoking 2 grams a day of cannabis, which he's spinning with tobacco, and also reports that his cannabis has a high THC content. He scores 13 on the severity of dependence scale, where over or equal to 3 out of 15 is indicative of cannabis-related problems. He's also smoking 15 cigarettes a day. He reports only drinking 3 standard drinks per week and reports occasional use of 10 milligram non-prescribed oxycodone, roughly about 1 tablet every fortnight. The patient states his longest drug-free period occurred 15 years ago for 6 months when he first met his partner, and he reports no history of significant substance withdrawal. Next slide, please. So as previously discussed, this patient is using tobacco, and tobacco withdrawal symptoms can overlap with cannabis withdrawal and may have similar intensity and time course. So table 4 here outlines the withdrawal features observed in this complex case and the possible management. So NRT may be considered during the withdrawal period and post-detoxification if the patient desires to quit nicotine as well as cut down or cease their cannabis use. The decision to recommend inpatient admission or outpatient withdrawal in this presentation relies upon an accurate assessment of the brief psychotic episode and their potential impact on the patient's functioning. Withdrawal from other substance use that may increase risk of adverse outcomes, such as alcohol, opioids, benzos, that's not present in his history, so that's not something that we need to worry about. The patient said he denies any current suicidal thoughts, but reports dysthymic mood that is typical for him. He states that his cannabis use is heavier at night in an attempt to improve his sleep, and ceasing his use in the last 60 hours has impaired his sleep quality. He reports that his partner of 15 years is highly supportive of his cessation attempt, and he wants to be committed to a substance-free relationship. In the end, the patient reported a preference for home detoxification. So he attended with his partner, who reports that she can help monitor him over the coming 5 days. And the patient has consented to attending primary care appointments daily over the next week. The main management approach to consider is, possibly a cannabinoid agonist off-label that could be slowly titrated upwards. And if the psychosis persists, then I would say, he needs to be transferred for an inpatient withdrawal, and that would be indicated. The GP did start quetiapine, an atypical antipsychotic, with daily use, and for him to have daily review over the next 5 days. The patient and his partner were also provided with psychoeducation on the cause and symptoms of withdrawal, exercises to cope with cravings, physical exercise, sleep hygiene, things like that. Admission to a CBT-based outpatient relapse prevention program was recommended and a referral provided. Next slide, please. So a bit about relapse prevention. So like I said, no pharmacological approaches have been approved to prevent the risk of relapse to cannabis use disorder during or after withdrawal. Psychosocial-based interventions are the first-line treatment, and the 2 most effective standalone interventions are CBT and motivational enhancement therapy, both with a similar efficacy. There is some evidence that combined CBT and motivational enhancement therapy produces better outcomes than either approach alone. And in the short term, studies have found that combined Mair and CBT doubles abstinence rates and reduces consumption by an average of 25% in those who do continue to use cannabis compared to non-active treatment. There is less evidence on the efficacy in the longer terms, like over 9 months after treatment. And then obviously we have other behavioural interventions like counselling, relapse prevention, mindfulness, exercise, things like that. Next slide, please. Another thing to bear in mind is that many patients enter treatment with moderation goals, and as clinicians, we need to adapt our approaches to work effectively with these patients. So reduced use is a common outcome in outpatient studies, but how long these reductions are maintained and whether reduced use improves psychosocial functioning remains unclear. So to retain patients with a moderation goal in a therapeutic relationship and to reduce the risk of future cannabis-related problems. Low-risk guidelines have been endorsed by a number of health jurisdictions and health experts, which we can see here in the table, and include things like suggesting that they use lower THC content products, exercising caution in combination with other substances, just things like that. Okay, next slide. So new developments. So the management of substance withdrawal typically includes pharmacological agents which reduce clinically significant withdrawal symptoms. Cannabis does not have any approved medications for medically assisted withdrawal, despite a well-recognized and clinically significant withdrawal profile. As discussed, there are a number of novel agents that have been examined with some promising results, such as nabiximols, dronabinol, quetiapine, gabapentin, and even nebulium for cravings. But this is an important avenue for future research, with some agents, showing some early efficacy. For this reason, cannabis agonists have been cautiously used off-label for cannabis withdrawal. But the mainstay, obviously, for withdrawal management has been psychosocial education, supportive counselling, and behavioural therapies. Next slide, please. So the legalization of non-medical cannabis use in a number of high-income countries has reduced cannabis prices and increased sales of high-potency cannabis products. The cannabis industry is currently lobbying to reduce cannabis taxes, opposing restrictions on maximum THC levels, and promoting the sale of high-potency cannabis, such as cannabis edibles, oils, extracts, and waxes, although the effects of these changes have not yet been formally evaluated. Increased use of high-potency cannabis is likely to increase risk of cannabis use disorder and the severity of withdrawal. Definitely public health messaging should include independent information and advice on the risk of using these higher potency cannabis products. Next slide, please. So just a bit about the current Australian guidelines. So nabiximols is the only medicinal cannabis included on the Australian Register of Therapeutic Goods. And like I said, it's a combination of cannabidiol and THC in a spray, and is indicated for muscle relaxation in MS. It is a Schedule 8 drug. Nabiximols are also available overseas, along with other cannabis products, including nabilone, dronabinol, cannabidiol, oral cannabis extract, herbal medicinal cannabis, and then obviously unregulated cannabis. Next slide, please. So I guess to conclude, as already stated, cannabis does not have any approved medications for medically assisted withdrawal at this time, and more studies are needed with greater sample sizes, and definitely with cannabis withdrawal as the primary outcome. Psychosocial based interventions are the first line treatments, things like CBT and motivational enhancement therapy. It says the potential to use cannabinoid agonists off-label. And I guess another thing, especially with patients that we have in Gorman, a lot of them are polysubstance use disorders, and it can be difficult to differentiate, I guess cannabis withdrawal versus something like alcohol, because there are so many symptoms crossing over. Next slide. So yeah, that's concludes my talk today. If you have any questions, feel free to ask.
Thank you, Georgie. A very thorough presentation on cannabis withdrawal. To everybody online, please post your questions in the chat or Q&A. I wanted to ask. I have to be honest. I hadn't read this particular review. About 3 years older. But I think a lot of there was a bit of crossover, obviously, with some of the studies. Dave mentioned metazapine for symptom withdrawal. I might have missed it. Did your review look at that? Because that's something we don't use a lot of. We definitely do type, and was there anything about mirtazapine for?
So there was a study that looked at withdrawal with CBT and another SSRI that didn't actually show any difference in withdrawal with the group that had CBT plus the SSRI compared with CBT plus the placebo. I can't remember off the top of my head how many participants were in that study, but yeah, no difference with that SSRI added in.
Okay, no, that's good to know, because I mean, obviously we don't use it, so it's good that someone's looking into those look, it's still being those sort of little sparks of potential are being looked at. If if the NHMRC said to you, Dr. Georgie Mair, we're going to give you $1 million to trial a medication for cannabis withdrawal, based on what you've read, what's the biggest flicker of a flame of having some potential?
Yeah, I think the medications like dronabinol and the biximols, I think the studies that used nabinol didn't have withdrawal as primary outcomes and were very, very small. But I think the studies on dronabinol definitely showed potential. It would just be good if they had the withdrawal as a primary outcome. And I feel like, I guess for me, just it being cannabinoid agonist, it kind of just makes sense that it should relieve some parts of the withdrawal. So I feel like that's where, I would put my money.
No, that's fine. I think I don't disagree with what you're saying. The only caveat I would add would be that most of the work being done around use of cannabinoids for cannabis treatment is for more long term. And so, and like you'd already sort of pointed out, some of these studies were studies where they're looking at the sort of more long term maintenance, kind of an offshoot of something like that. And so that makes it challenging in terms of, where do you, and may well sort of hinder the ability to actually study this well, because people are going to look at the more long-term effect rather than the short-term symptomatic and so forth. I've got a question from Krista, who is more than welcome to unmute herself as well, but I'm happy to ask it. But Christy, did you want to ask it yourself?
Sure. Can you hear me?
Yeah, absolutely.
Thanks, Georgie. Thanks for unpacking all of that for us. I guess my question was whether the paper discussed much about commencing psychosocial therapy so early in the piece during an acute withdrawal, and what the benefit or the gains that might be seen from that, or whether we need to wait till people recover slightly and have a lower withdrawal score, meaning less symptoms, before we commence that kind of intervention.
Yeah, I mean, the studies didn't particularly comment so much on whether there was any benefit in including that therapy sooner rather than later. But I see what you're saying. Like, I guess in the withdrawal phase, there's a lot of agitation, things like that. Like, maybe it's not as it's not that beneficial until actually they're a bit more stable. But the studies that I read didn't really comment on sort of early versus late.
What was I going to say? Thank you, Chris. Did you have a follow-up there?
Am I still? Oh, there, I'm unmuted.
No.
No, I suppose not so much a follow-up. I guess it's just an interesting sort of question about whether that's impacting on your effects in the various models of trials, I guess.
Yeah, it's certainly something that gets kind of, they do try to randomize out and blind out these days. So, and does always make a challenge with assessing things in the withdrawal stage. So yes, if you've got any questions out there, please pop them in the chat. I see Nadine, you're unmuted. Do you have a question?
I do. Georgie, that was a really great rundown. And I guess the question that's kind of most people would ask would be like a question that I received from a DASIS GP last Friday night. And they said, I've got a client here who is going to cannabis withdrawal. What can I do? So, I mean, given that a lot of what you described is kind of still in the kind of experimental phase, what would you recommend to a GP that calls you up for advice? I mean, 30-second blurb.
I mean, yeah, I guess establishing if they have any other polysubstance use that's more dangerous for their withdrawal that they're also abstaining from, and other current psychiatric conditions if they do have any medical history, and if they are low risk, then I'd probably and they're not having any psychotic features, and I'd probably suggest something like a short course of Valium or olanzapine for agitation, and recommending things like, if they're having, abdominal cramps, Buscopan, paracetamol, just symptomatic management, basically. But I wouldn't be giving out huge scripts for olanzapine or Valium. And I think also ultimately just stressing that, if the patient isn't coping at home, then they need to present to ED for more support. And then also recommending that GP, I guess, like I said, 'cause the best evidence at the moment is still for the psychosocial models, is recommending that GP definitely organise something like CBT or motivational enhancement therapy.
Thanks, Georgie.
Yes, thanks, Georgie.
Would you add anything different, Nadine? Would you add anything else? Or change anything?
I personally, I'm pretty reluctant to recommend GPs prescribe benzos for anything. So I'd be cautious with that, particularly with something like the cannabis withdrawal syndrome that does go for quite a long period of time. So it would really depend on the kind of supports at home, the motivation of the client. The driving, all those kind of risk assessments as well, and certainly make it time limited and stage supply.
And I think sort of the most important thing, and like I said, when I had that slide, the graph of what to expect, I think the main thing is, patient education and sort of empowering them to understand, the time course of their withdrawal and what to expect, and to try and educate them not to get frustrated, and just basically lots of reassurance, I think.
Yeah.
Thanks, Nadine, for your question. Thanks, Georgie, for your answer. I was going to say, we did mention that mirtazapine study, 11 was the number I've managed to dig out here. So yeah, 4 numbers that was from one of the studies, but I don't know if there's been further on that since. It's all very small scale. And just to comment as well about nabiximols, which is Sativex, and I don't know if people have prescribed it. There's obviously it's not cheap. There are challenges in terms of because it's a spray. Dosing is a challenge, and availability as well, of course. But what was I going to say? And then there's all sorts of you can get approvals for it, but it is a challenge to it's a time-consuming and challenging thing to do. So it's not and look, at this stage we don't have the evidence to recommend it, but just for those of you who are thinking about it, it is really tough to do anyway, even if you want to do it. So I think we're still a little bit away from doing it, even just from a practical point of view. Well, it's 3:32. We might wrap it up there. Thank you very much, Georgie, for your presentation today. And next week, you're all unfortunate enough to have me presenting on dexmedetomidine in alcohol withdrawal delirium. So we'll do a bit of a deep dive in the literature, especially as it has come up in the national guidelines, and something that's relevant not only to to St Vincent's, but also it's also come up in the DASIS. And so at least two of the LHDs involved in this forum have asked about this recently. So hopefully we'll catch you all then. But in the interim, please join me in thanking Georgie Mair.
Thanks, Georgie. That was great.
Thanks, guys. Thank you.
Thanks, Georgie.
Cheers.